Okay, folks, thank you so much for visiting our channel today. This is an exclusive channel for medical students who are preparing for USMLE exams and other entrance exams. And today I would like to talk about Chiari syndrome or hepatic venous outflow obstruction by a thrombus. So, how do you see this question? Let me read you this question I wrote today. A 44-year-old woman complains of severe abdominal pain and a feeling of abdominal fullness. She has been vomiting off and on for the last week. First, she got abdominal pain and then the abdominal distension after 2 days. She gets short of breath on exertion. She has been having normal bowel movements. Her stool frequency and stool color is normal. She takes vitamin tablets and a daily oral contraceptive. Our past medical history is significant for several admissions for alcohol related complications and paroxysmal nocturnal hemoglobinuria. Her sister had developed a deep venous thrombosis at age 48 years. Her temperature is 99 degrees Fahrenheit, heart rate is 112 beats per minute, blood pressure is 87 by 57 millimeters Hg. Respirations are 19 breaths per minute, oxygen saturation is 96% or room air. On physical examination, she is febrile. She has scleral icterus, otherwise eye exam is normal. She displayed shallow and rapid respirations. She has a protuberant abdomen with right upper quadrant tenderness and painful hepatic enlargement measuring 7 centimeters below the costal margin and a fluid wave. You can see visible dilated veins on her abdomen and back when standing. There is moderate ascites. She has 1 plus pitting edema bilaterally. Rectal examination is normal. No occult blood was detected. Nervous system examination is normal. What is the most likely diagnosis in this patient? We have these choices. A. Chiari syndrome. B. Cystic fibrosis. C. Niemann-Pick disease. D. Lower gastrointestinal bleeding. And E. Celiac disease. What is the correct answer? So, if you analyze this question, this woman in her 40s, she developed a protuberant abdomen, she developed abdominal fullness, and look at the risk factors she has. She is alcoholic and she has different admissions in the hospital for alcohol related problems. And she is also taking oral contraceptives. Okay, that is the risk factor for thrombosis. Then she also has a history of paroxysmal nocturnal hemoglobinuria. Okay, so that is also a risk factor for hepatic venous thrombosis. So she has many risk factors, and also she has a sister who developed a deep venous thrombosis at age 48 years. So there may be some family history of genetic links to this problem. And then if you see her physical examination, there is right upper quadrant tenderness, there is liver enlargement, and there are visible distended veins on abdomen and back. So that's a very good clue to hepatic venous outflow obstruction by a thrombus or Chiari syndrome. Whenever you see these words, like there are visible veins, there are visible vessels on the abdomen and back when the patient is standing, so that's a very good clue to Chiari syndrome. So you should always think about Chiari syndrome when you see those veins. And in examination, that's a very important clue to this diagnosis. And if you think about the diagnosis, the initial test of choice is ultrasound. Okay, a duplex Doppler ultrasound of the abdomen. So you do this ultrasound, you can clearly see a thrombus in hepatic vein. So the portal vein is pumping blood into the liver, and then the hepatic vein is collecting that blood and taking it back to the heart. So in that transaction, when the thrombus happens in the liver, there is that backflow, there is that congestion. So if you do a liver biopsy in this patient, you will see centrilobular congestion. Okay, the centrilobular congestion with fibrosis and necrosis. That's a clue to Budd-Chiari syndrome. So whenever you see those words, centrilobular congestion, you should think about this syndrome, and that's what exactly you see on a liver biopsy. It is also called nutmeg liver. Nutmeg liver because it looks like a nutmeg when you do this biopsy. So, liver biopsy is another way to diagnose this problem. You can also do CT scans or MRIs, but they are more expensive. So, we start with ultrasound. Liver biopsy is also unnecessary because many times it creates complications, and sometimes, especially when they are very hemorrhagic, liver biopsy can be deadly in those patients. So, you don't touch liver. You can safely diagnose this condition using an ultrasound. Coming to treatment, just think about what is happening. There is a thrombus. So, you want to prevent thrombus formation. So, you have to do anticoagulation with low fraction in heparin, and also you can use warfarin or even direct oral anticoagulants. So, there is a thrombus, think about anticoagulation. And what else can you do? You can use thrombolytics. You can cut that thrombus into pieces using thrombolytics. What else can you do? If you can't destroy it using medicines, there are invasive procedures like surgery, like a surgical shunt from portal vein to a proximal branch of the hepatic vein. You can also do TIPS, transjugular intrahepatic portosystemic shunt. Shortly, TIPS. It helps to connect a branch of the portal vein into hepatic vein. So you're basically bypassing this thrombus. You're just keeping it in place. You can also send a balloon, and you can open that balloon. You can put a metallic stent through this thrombus and reopen the whole blockage. So there are many ways to treat this problem. So the other point you have to think about it, 50% of the cases of Budd-Chiari syndrome happen in patients with polycythemia vera or essential thrombosis, which are like myelodysplastic disorders. So whenever you see a patient having repeated attacks of hepatic venous thrombosis, you should also think about polycythemia vera or myelodysplastic syndromes, and you should screen these people with JAK2 V617 mutation, which is commonly seen in myelodysplastic syndrome. So today, many experts are actually recommending JAK2 V617F mutation screening in all patients who come with hepatic venous thrombosis. So when you look at this problem, first always think about what is happening, pathology. Based on pathology itself, you can interpret the symptoms because there is a thrombus blocking hepatic veins. The pressure will fall on portal veins. Portal hypertension happens because the splenic vein also empties into the portal vein. There would be splenomegaly. Because superior mesenteric vein and inferior mesenteric vein, they supply the intestines. They collect blood from the intestines and they empty into the portal vein. Whenever there is increase in portal hypertension, what happens? There is that backflow into the intestine, causing abdominal distension and ascites. So you will see ascites in these patients. You can also do diagnostic paracentesis. You can take that fluid out and you can examine the ascitic fluid, its concentration. When you check the concentration of ascitic fluid, you would know whether it is a chronic condition or an acute condition. So In that way, you can interpret the symptoms, and based on the symptoms, you can also interpret the treatment of this condition and also the screening tests you have to do. So very, very important question. Make sure that you understand this very, very well. And if you have any questions, you can post in the comment section and visit our website supertestcourse.com, and this website is built for you and it is still in development. It will be we will be launching this website soon, and you will have a nice question bank, almost like 1,000 questions to prepare you well for USMLE exam. Alright folks, that's all about for today's question. Please subscribe to our channel, get the notifications, and also post your comments so that others can be benefited from your preparation. Thank you.